move on to Dr. Prashant. Dr. Prashant is an ex-glaucoma consultant from Shankar Netralaya, Kolkata, and now he is a senior consultant in BBI Foundation and Netralayam. Dr. Prashant?
Tanya, please, and thank you so much, ma'am. Tanya, please stop sharing your screen.
Okay.
Thank you. Good evening, everybody. I'll be talking about specific indication of performing glaucoma surgery. First of all, I would like to thank the organizing committee for inviting me for this webinar. So my topic is who are the patients who require trabeculectomy and who are the patients who require a tube or stent surgery for the control of intraocular pressure. So what are the specific indications of doing trabeculectomy or a drainage implant? So as we know, for trabeculectomy, the indication of doing a trabeculectomy is all the patients who have uncontrolled intraocular pressure with maximum tolerated medical medication. So they are the candidate for doing a trabeculectomy, and also patients in which the pressure is okay, but the field is showing a progressive visual field loss. Those are the patients in which, as Tanya has described, they require a little less target IOP. So in those patients, we require a lesser IOP that can be achieved with surgery only. So those are the candidate of doing a trabeculectomy. Also, patients who are well controlled with medications, but and they are on more than 2 medications, and they eventually develop cataract. So we can combine a cataract surgery with a trabeculectomy. So the only criteria of having a good trabeculectomy, a good result of trabeculectomy, is to have a good conjunctiva, a good healthy conjunctiva which is untouched and non-scarred, non-inflamed. So this is the criteria which makes your trabeculectomy more successful. So we approach trabeculectomy by 2 ways. One is fornix based, one is limbal based. As we know, fornix based is easier to perform because the approach is easy surgically. We need less assistance. The only problem is we get more chances of bleb leak. Limbal based is really difficult, but we get a more secured wound. If you compare overall success rate and specific indication, they are similar in both the categories, both in fornix and limbal based trabeculectomy. So it is essential to use anti-metabolites in almost all cases, except few specific contraindication like pregnant women. The role of mitomycin is to decrease the inflammatory reaction or decrease the proliferation of fibroblasts that can cause your trabeculectomy to be failed. So fibroblast proliferation can be prevented or can be reduced by using mitomycin during the operation or by using 5-fluorouracil injections in subconjunctival space in post-op period. So these are the adjuvants which will make your surgery more successful. Next, we discuss about glaucoma drainage devices. So there are basically 2 types of glaucoma drainage devices, as we know. They are non-valve and the valve one. So non-valve, they don't have any valve, so they provide resistance to outflow. All the glaucoma valves, they work by, so they are the implant. So one end of the implant is put in the anterior chamber and one is in the subconjunctival space. So drain the aqueous from to the medium of a tube from anterior chamber to the subconjunctival space. So one is non-valve, one is valve. Non-valve don't have any valves, so they offer the resistance by the fibrous capsule which is formed over the bleb. And valve have intrinsic system of a valve. So if the pressure is less, then the valve is closed, so the flow of aqueous is blocked, so the drop of IOP is less. So the chances of hypertonia is less in valve implant. This is a typical valve implant, which is and Aurolab has developed an implant which is similar to this. This is also a non-valve implant. So this is developed by Aurolab, which has fenestrations here. So the valve which is most commonly used by us is Ahmed glaucoma valve, which is very safe. It's a valve implant. So FP7 model is the model which is used in adults. So this portion of the valve of the implant has a valve which has silicone elastomers, which blocks when the IOP is less than 8 millimeters of mercury theoretically. So what are the specific indications of using drainage implant in glaucoma patients? So all the cases of uncontrolled intraocular pressure on maximum medication as described in the earlier slide, which are the indications of TRAB. But the cases which are failed by TRAB or most likely to be failed by TRAB, or the result is the success is going to be very less, are the indications of doing GDT. So failed trabeculectomy is one indication of doing glaucoma implant. Cases of IC syndrome, uveitic glaucoma, Sturge-Weber syndrome, neovascular glaucoma, where there are chances of high inflammation or very high inflammation post-op period. Glaucoma surgery along with penetrating keratoplasty, and glaucoma surgery in patient post-retina surgery or patients with silicon-filled eyes. These are the indications of specific indication of using a glaucoma drainage implant in the first place. For example, this is the case of IC syndrome. So this, we can see patches of IC trophy and also metal bitten appearance in the periphery, portion of the cornea. So if you do a normal conventional TRAB in such cases, you will find very engorged vessel in post-op period, very engorged, angry-looking vessels. So the inflammation is huge in post-op period. Because of very aggressive inflammatory response, there is marked chances of subconjunctival fibrosis. And also specifically, and this applies to uveitic glaucoma and neovascular glaucoma as well. And one thing specific to this IC syndrome is this endothelial cells, migrating endothelial cells also comes and blocks the ostium. So that is another cause why the chances of conventional trabeculectomy is of success is very less in cases of IC syndrome. However, if you put a drainage implant here in such cases, since the length of the tube, a significant portion of the tube remains inside the AC and the tube is away from the angle, there is less chances of this tube is to get blocked by the proliferating endothelial cells. So the chances of getting it blocked by endothelial cells is very less, and also it is least affected by the inflammatory response. The similar mechanism applies in uveitic glaucoma. So you can put a tube in any portion of the eye, superior, inferior, any quadrant. Also, the cases of corneal opacity with uncontrolled intraocular pressure. For example, a patient had a fungal corneal ulcer or other corneal ulcer, or even trauma-induced corneal opacity, who also developed trauma-induced secondary glaucoma and uncontrolled IOP. Such patients are good candidates for performing a penetrating keratoplasty along with a tube implantation, because the chances of success of a conventional trabeculectomy is quite less in cases of post PK eyes. So we can put a tube here like this along with penetrating keratoplasty. The only key here is to put the tube away from the graft so that there is no chance of touching the graft, the tube touching the graft. If one tube fails, we can also try putting a second tube. So this is the first tube, and after putting the first tube, the pressure was still high. The second tube, second AGV can also be implanted in such cases. So even if the surgery is less successful after putting one tube, you can also try putting a second tube. So there are chances of we can control the intraocular pressure by putting two AGVs. So as I described, the neovascular glaucoma behaves similar to IC syndrome or something, but here the inflammatory response is even more severe. As we know, because of the release of vasoproliferative factor, there is development of NVI and NVA. So because of NVI, the manipulation in the anterior chamber is even more difficult. So if you go for a conventional trabeculectomy, and we know we conventionally perform a iridectomy in cases of trabeculectomy. So since we have a fluoride vessels here, if you perform a iridectomy, there is chance of huge bleeding inside the eye while doing the surgery also. And also, if there is no bleeding, this is a study published in American Journal of Ophthalmology. They've said that the chances of success is less in neovascular glaucoma. It is around 62%, and which decreases, which declines by 51% after 5 years. And success rate is particularly less in patients, younger patients, and also post-vitrectomic patients. So in such cases also, performing a tube implantation offers a better result as compared to a conventional trabeculectomy. Having said that, it is not essential that you have to perform a tube only in cases of all cases of neovascular glaucoma. You have to assess the condition, assess the inflammatory response of the particular patients. One advantage of using a tube implant, you can put it in any of the area of the eye. So you can put it in the sulcus, as in cases of post PK eyes or post DSEC eyes. You can put it in the sulcus so that tube remains away from the cornea. you can put it in. So it is here, the tube is behind the iris. You can put it in the anterior chamber if the cornea is normal like this. You can put it inferiorly also, in inferior temporal quadrant, if the superior area is very thin. So that is one big advantage with tube, which is not applied with trap. So trap only we can do it in the superior area. Tube we can do it in superior quadrant, superior in temporal and inferior temporal quadrant also. So here also you can see the tube is in the sulcus in superior temporal quadrant, and in this PKI, post PKI, here is the tube in the sulcus. Now, if you compare the post-operative complications of trab and tube, we will find that trabeculectomy will have most post-op complications. A simple reason behind it is the IOP control is also much more significant with conventional trabeculectomy as compared to the tube surgery or tube implantation. And most of the complications of both the drainage device, both the drainage technique is hypotony. So all the complications are related mostly to the hypotony, and obviously because trabeculectomy offers a more significant IOP control, the chances of hypotony is much more. Additionally, there is chances of wound leak here in trabeculectomy, which is not there in which is very less in the case of trab, and the chances of hypotony induced serous square detachment is also higher in trabeculectomy. However, in implants, the chances of hypotony is significantly less. Theoretically, it should not be there, but practically it happens because there may be wound leak from the margin of the tube also. There could be tube obstruction, like in this picture we can see the tube is obstructed, the tip of the tube is obstructed by the iris. There can be tube exposure, there can be tube exposure explant also. And also if the blade is huge, it can produce ocular motility disturbance. And cornea touch, we should be avoided by putting a tube away from the endothelium. Sometimes we may need a repeat surgery also. So the conclusion is trabeculectomy is a highly successful and very cost-effective procedure, and it should be considered as a primary mode of intervention in all glaucoma patients. And with the judicious use of anti-metabolite and a very close follow-up, like you use the metabolite very judiciously, even in cases of IC syndrome, neovascular glaucoma, and uveitic glaucoma, the success can be substantial. So mitomycin should be used properly, and keep these even in the patients of IC syndrome and neovascular glaucoma. In neovascular glaucoma, if you have to do a trap surgery only, give an injection of anti-VEGF and do a surgery after a week or so that the neovascularization is inhibited or abolished, and you may skip doing a trabeculectomy here, iridectomy here, and keep the patient in a close follow-up, give serial injection of 5-FU. That can make your trabeculectomy successful even in these challenging cases also. However, there are specific indications in which choosing a drainage device is only the best approach, like silicone filled eye. So in such cases, don't think twice of going for a drainage implant, even if it's less cost effective. But in a long run, it is definitely much more successful. Thank you so much.
Thank you, Dr. Prashant, for your very elaborate and nice presentation.
I would like to ask one question about this trabeculectomy and shunt, this one. And it is because on this neovascular glaucoma, if there is a florid NVI we are seeing and patient needs urgent surgery, we don't have time to wait for 3-4 days. Say patient is having 40-50 IOP, we can't give that anti-VEGF and wait for 3-4 days to NVI to resolve, and after that we'll plan one trabeculectomy surgery. In those are the situation, what you would prefer to do? Directly go for a tube first, primary tube, or still you will try to take a chance with trabeculectomy?
Yeah, can I answer this?
Yeah, Prashant.
In case of florid NVI, pressure is very high. And you anticipate that the chances of success of trabeculectomy is very less. In such cases, we can go for a tube implant directly. I think that is a safer approach to do, unless there is financial constraint and all. Because doing a trap in such cases is a risky thing. A sudden drop of IOP and manipulation of iris can result in hyphema and can further aggravate high intraocular. In such cases, we can directly go for a tube